This is chapter 29, Promoting Premenstrual, Perimenopausal, and Menopausal Health. So some of this we've talked about previously when we talked about pregnancy and we talked about some disorders. So a lot of this chapter is going to be a review. I'm just going to briefly touch on some of the things because we talked about this prenatally and all that stuff toward the beginning of the semester. But I will just kind of briefly touch on it here in this chapter as well. So premenstrual syndrome, this affects many women during the reproductive years. It is considered the presence of behavioral, emotional, and physical symptoms. It usually occurs during the luteal phase of the menstrual cycle, and the symptoms will cease within a few days after the onset of menses. And you can see the different symptoms that a person can experience here on the slide. Premenstrual syndrome actually affects more than 80% of women, and it can significantly impact their daily functioning. So you can also see the symptoms on page 941, box 29-1. So the phases of the uterine cycle. The first phase is called the follicular or proliferative phase. This is from the end of menses through ovulation. Then you have your luteal phase, which begins at ovulation and ends with the onset of menses. And then the actual menstrual phase is the degeneration of the endometrium and the onset of menses. So just kind of be aware of what the different phases are of the uterine cycle. Premenstrual dysphoric disorder. So this is a more severe form of PMS. It's those symptoms exacerbated where it becomes severe and disabling, especially emotional symptoms. It's most frequently reported that patients experience abdominal bloating, anxiety, tension, breast tenderness, crying episodes, depression, fatigue and a lack of energy, irritability, difficulty concentrating, appetite changes, thirst, and also swelling of the extremities. Now, PMDD more commonly affects women between 20 and 40 years old, and these symptoms usually worsen as the woman approaches menopause. So as she gets closer to that menopause age, the symptoms of PMDD will actually start to increase or worsen. Causes of premenstrual disorders. So the exact cause has not been determined, but it seems to be a lot of factors, or what we call multifactorial. So those can include all of these things listed on the slides: variations in their hormones. There's a genetic predisposition a lot of times, biological factors, psychosocial factors, sociocultural factors, and also neurotransmitters. So all of these things can play a part in causing women to have premenstrual disorders. Diagnostic workup for PMS and PMDD. So first, it's important to rule out any underlying causes of PMS or PMDD. The symptoms that they experience, it's important to rule out any underlying causes that could mimic those symptoms. So a detailed history with a focus on the medical, psychosocial, psychosexual, and substance abuse histories. Then a complete physical exam will be performed. Laboratory tests as appropriate to rule out other disorders, like I mentioned earlier, like hypothyroidism. So there's different types of tests that can be done for different disorders. And then a record of the woman's symptoms over a 2 to 3 month period. So it's important for her to keep a record of how she's feeling throughout the month. Is it related to her cycle? Is it not? Those type things. And you can look at different boxes on page 943. There's a diagnostic tools box. There's a labs box, an assessment tools box, and also a patient education box. And all of those are on page 943. So I said it's important to rule out other conditions. So here's some other things that can mimic symptoms of PMS: dysmenorrhea, hypothyroidism, depressive disorders, pain disorders, and also generalized anxiety disorders. So, it's important to do that full history, the assessment, the labs, all those things, so that we can actually determine, is it PMS or PMDD, or is it one of these other conditions? So they can be treated appropriately. Diagnostic criteria for PMS and PMDD. So on the left side, they have to have at least one of the following: anger or irritability, anxiety, edginess, nervousness, depressed mood, or moodiness. So at least one of those they have to have. Then they have to have at least 5 of these other additional symptoms: appetite changes or cravings, decreased interest in usual activities, difficulty concentrating, fatigue, feelings of being overwhelmed or out of control, insomnia or hypersomnia, and also physical symptoms. So 1 on the left side and 5 additional symptoms on the right side. Patient care management of PMS symptoms. So there's a lot of different ways to treat these symptoms, and you want to give that information to the woman to help her make the best decision for her. So physical activity, doing exercise, different things like that. Non-pharmacological treatments, you can look at those that are listed in your book. Once again, exercise, but other things, massage, things like that. Non-steroidal anti-inflammatory drugs can be given. Oral contraceptives can also help. Antidepressants can be given. And then other medications, and I want to explain this for a minute because these are off-label medications. So not originally prescribed for PMS or PMDD. So off-label medications for PMDD would be, some examples would be something like buspirone, alprazolam. Those can be given for PMDD, not originally prescribed for that, but they can be used for that off-label. And for PMS, an example would be like aldactone. That can be one that's used off-label as well. So think about those medications that can help with some symptoms of those PMS or PMDD, but they're not originally prescribed for those particular disorders. Now, climacteric means that this is a transitional time in a woman's life. It's marked by declining ovarian function and decreased hormone production. And it usually begins at the onset of ovarian decline and ends with the cessation of postmenopausal symptoms. So that is kind of considered the climacteric period in a woman's life. So then menopause, we get to menopause. There are different phases of menopause. So there's premenopause, which is the time from the beginning of perimenopause to the time up to the last menstrual period. And when we get to perimenopause, this is the time preceding menopause. So this is usually about 2 to 8 years before menopause actually is there, and it lasts about 4 years. So you can start having those perimenopause symptoms about 2 to 8 years before the actual menopause occurs. Menopause is considered the last menstrual period, and it has to be at least 1 whole year without menstruation. So that is when a person is said to have entered into menopause, when they have their last menstrual period and it's been 1 whole year with no menstruation. Usually menopause will occur between 45 and 55 years old, and about 50% of women actually experience menopause before age 50. So it can be any time in that range, but half of the women go through menopause before age 50. Then postmenopause is considered obviously after menopause. So it's after your menstrual periods have ceased for 12 consecutive months, then you're considered in that postmenopause state. Symptoms of menopause. There are a lot of symptoms that women experience during menopause, perimenopause leading up to menopause. So you can look on page 946, table 29-2, and it shows you premenopause and menopause symptoms. So there will be hormonal changes, menstrual cycle changes. They'll start having hot flushes or flashes, like their face will feel flushed, or they'll have flashes of heat come over them. Night sweats, sleep disturbances. They will have vaginal changes, genitourinary tract changes, skin and hair changes, and also breast changes. And you can look at all those in detail on page 946. Long-term effects. Cardiovascular disease. Now we're talking about menopause. So long-term effects, there's an increase in blood pressure, there's lipid changes, atherosclerosis can be experienced. And then musculoskeletal effects of menopause, they have rapid bone loss and they are at risk for osteoporosis as well. So what do people do for menopause? So there are complementary and alternative medicine treatments. Alternative medical systems, you can look on page 950, box 29-3 to see those alternative medical systems. Then you have biologically based treatments. This would be like your essential oils, your tea infusions, homeopathic preparations, those type things that would be considered biologically based. Then hormonal therapies. So you can see on page 952, there's a medication box that talks about hormonal therapies. Estrogen therapy is usually recommended for longer duration of treatment if you're doing the hormone-based therapy. Hormone therapy is not without risk though, so it's important to educate your patient on all the options and the risk factors related to those so they can make an informed choice. So you can look on page 952, box 29-4, and also 953, box 29-6, and it will show you some education and risk and things like that of hormone therapies. So it is important, like I said, to make sure you're educating your patient on those and the risks that are associated with those hormone therapies. Now, there are different types of treatments as far as hormone therapies. So there's oral medications, there's gels, there's creams, there's patches. And so it depends on, what type of treatment they want as well. So you can look on page 953, box 29-5, and it shows you all these examples of different types of hormone therapies and then what type of, whether it's gel or oral or whatever. So there are some contraindications to estrogen therapy. So you need to make sure that the patient is aware of those, that you're aware of that, and the patient is aware of that, so that you can make sure you're educating them on being safe and not doing these particular hormone therapies if they have contraindications. So there's a focus on safety box, page 953, that you can look at related to those contraindications. Now, I'll put bioidentical compounds here at the bottom. So let me explain what these are. These are chemically derived hormone therapies that are designed to match the hormones produced in a woman's body. So they make these, based on the fact that they're very similar to a hormone in a woman's body, but they're chemically made. Okay, the FDA has approved some of these. And you can look on page 955, box 29-7 to see which ones the FDA has approved as far as those bioidentical compounds. Then there are non-hormonal prescription medications. These may be antidepressants, anticonvulsants, antihypertensives. A lot of times those are going to be treating the symptoms that are related to menopause. Okay, so that is the end of chapter 29.